اوكي بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته ومساء الخير لكم جميعا. أصالة عن نفسي ونيابة عن الهيئة السعودية للتخصصات الصحية والزملاء المتحدثين، يسعدني أن أرحب بكم هذا المساء في محاضرة علمية نغطي من خلالها الأدوية المستخدمة في الوقت الحاضر للتعامل مع جائحة فيروس كورونا COVID-19. أطلقت الهيئة السعودية للتخصصات الصحية مبادرة امتنان، والتي تهدف لدعم الممارسين الصحيين وتقديرا لجهودهم الكبيرة في حماية المجتمع والتصدي لجائحة فيروس كورونا. وندوة اليوم هي جزء من سلسلة ندوات علمية تقدمها الهيئة تغطي مواضيع مختلفة لمواجهة هذه الجائحة، وهي معتمدة كساعات تعليم مستمر من قبل الهيئة. So I would like to start by welcoming everyone to this educational webinar. My name is Mohammed Asiri, a consultant clinical pharmacist and assistant director of pharmacy services at King Abdulaziz Medical City in Jeddah, National Guard Health Affairs. I will serve as a moderator for this webinar that will discuss pharmacotherapeutic interventions for COVID-19. Joining with me in this webinar, we have two clinical pharmacists specialized in infectious diseases, and I will introduce them one by one before they start their presentations. During each presentation, we invite you to send questions that can enter in the question and answer tab found in the bottom of the webinar screen. And at the end of the presentation, I will pose question that is relevant to the webinar objective to our speaker to discuss them. We will try to get as many questions as we can, especially with the high number of participants in this webinar. We are so glad to know that there are more than 14,000 people who signed up for this webinar. So without further delay, please allow me to introduce the first speaker. Dr. Khalid Al-Ja'li is an assistant professor and infectious diseases clinical pharmacist in the College of Pharmacy at King Abdulaziz University in Jeddah. He is also the head of Health Interprofessional Research Branch in the University Vice Presidency for Development and Head of Research Unit in the Health Promotion Center at King Abdulaziz University. Dr. Al-Ja'li is a research fellow in the College of Pharmacy, University of Arizona in the United States. He completed his pharmacy practice residency training at St. Elizabeth Medical Center, which is a Tufts University affiliated hospital. And then he completed his specialized residency training in infectious diseases pharmacotherapy at BID Medical Center, a Harvard Medical School affiliated hospital in Boston, Massachusetts. Then he completed both infectious diseases and antimicrobial stewardship pharmacy fellowship and Master of Science in the clinical translation science at University of Arizona. So Dr. Khalid Al-Ja'li, please go ahead. If you can, please open the microphone, Dr. Khalid, and get started.
Okay. Can you hear me, Dr. Mohammed?
Yes, go ahead.
Okay, excellent. Assalamu alaikum. Good evening, everyone. Thank you for joining us in this webinar. It's my pleasure to participate in this webinar. Thank you so much for attendance. Thank you for the Saudi Commission for Health Specialties for the kind invitation to talk about this topic, which is, of course, a very hot topic now. The focus of our webinar going to be about the treatment or management focusing on pharmacotherapy of COVID-19 infection. There are a lot to cover, so we decided to focus on the treatment or agents used for COVID. Just a quick introduction. Already, the topic has been covered in previous lectures organized by Saudi Commission for Health Specialties. So I will not go over details, but just quick reminder: the coronavirus family include a number of low pathogenic viruses, which can cause common cold. However, we have experienced and seen some high pathogenic viruses. For example, SARS-CoV in 2003, MERS-CoV in 2013, and now SARS-CoV-2 which is called COVID-19. COVID-19 virus is an RNA virus. It is transmitted very fast. This is a big problem. We don't have approved medication for this virus for treatment. As you know, approval takes time, but we might use some medication that already approved for other conditions, or we might use some new agent as a compassionate use. We don't have a vaccine yet, of course. It takes time, maybe at least a year. We have a lot of literature. Many of them have poor quality and has many limitations and methodological flaws. Some of them are conflicting. So we'll try to go over those literature and give an update about them. Before going into the agents, I think we have to comment on some medication which has been very debatable. Some of them, it went viral in the social media. So I think I have to comment on those just very quickly. So ACE inhibitors and ARBs, you might have heard in the news, social media, that these agents might worsen COVID infection. Some maybe patient might started to stop their medication. So what is this all about? Basically, if you look at the mechanism, let's talk first about something important called AC2 receptor. The AC2 receptor, or angiotensin converting enzyme 2 receptors, these are the point of entry into the human cell. And this is expressed near the human epithelial cells surface, like the lungs, and the virus bind to these receptors. So it was found in animal model that the ACE inhibitors and ARBs might increase the AC2 expression. So it might lead to more binding, more entry, and worse outcomes. This was the fear. However, we don't have any clinical evidence, nothing that proved this. Actually, on the other hand, we have some data indicate that the ACE inhibitors and ARBs actually might be beneficial in those patients. So some previous data showed that these agents might decrease the lung injury in certain viral pneumonia by reducing the angiotensin converting enzyme and the angiotensin 2, which is because ACE inhibitor convert angiotensin 1 to angiotensin 2. So actually, if you reduce those substances, you can maybe reduce the lung injury. So it's not correct, at least for now, that these are bad for COVID. No, nobody should stop them. Actually, several professional societies in different specialties recommended continuing these agents. Very important. Actually, also, there are, I think, at least 2 ongoing trials with losartan in COVID-19. So actually, it might be beneficial. It's not correct that, for now, that it can worsen the outcome. Nobody should stop them because of this purpose. There is a study, not published yet, but it's available as a preprint, and I will show you in this lecture a lot of preprint. So not peer-reviewed yet. Many of them are available in MedRxiv website, like this study by Lou et al. In this study, basically they looked at 46 patients. They were elderly with COVID-19 infection, and they found that the ARB use was associated with reduced risk of severe disease. They didn't do any adjustment, but they found an association. So in this case, it was beneficial, maybe. Another study already published. The title might be a little bit misleading. It says it improved the clinical outcome, but if you look into the manuscript, there was no difference statistically in clinical outcomes. Maybe some differences in some markers. Again, we didn't see so far any publications that showed worse outcome. NSAID, another thing, went viral in the social media with ibuprofen. And all of this started because because of Twitter, and because the French Minister of Health suggested avoiding NSAIDs. Do we have evidence? No, we don't have evidence. We only have few data here and there. They suggest NSAID might upregulate AC2. But in general, nothing new, nothing specific so far with good evidence that indicate we should deal with them differently than we usually do. As you know, NSAIDs, they are not the first line in many cases. They have more side effect compared to paracetamol or acetaminophen. So use it as you usually do. Nothing specific really on COVID until now. Corticosteroids, another very, very debatable medication. But generally, if you look at most societies, generally they recommend avoiding corticosteroids unless the patient have acute respiratory distress syndrome. In that case, it became more debatable. But in general, we don't want to use them probably. But in ARDS, there is more debate. Some say you can use it in that case, and some maybe experts say, well, it's not clear, we don't have evidence. And we don't have a good evidence. We have mixed data, sometimes conflicting, based on low quality of evidence. We don't have any randomized studies yet. What I found only for retrospective studies. And they have a lot of problem. We have confounding by indication. Patient who are going to get corticosteroids, likely they are sicker. So it's difficult to make a conclusion that steroids increase the mortality, for example. We can't do that unless we have a good RCT. Without further delay, let me go and start with the agents for COVID-19 infection, the focus of our talk today. This is a nice picture from a recent review in JAMA. You can see some of the medications here. Tocilizumab, we're going to talk about it today. It's bind to IL-6 receptor. Also, the chloroquine, hydroxychloroquine, also have an effect on IL-6 and IL-1. When you go inside, the chloroquine, hydroxychloroquine, can also inhibit viral entry and endocytosis. Then we have the chymotrypsin-like protease. This can be inhibited by lopinavir, for example, which is used for HIV. Then we have the RNA-dependent RNA polymerase, which can be inhibited by ribavirin, remdesivir, favipiravir. I'm going to start with Okay. I'm going to start with of course, hydroxychloroquine and chloroquine. Probably they are the most commonly used now for COVID, although the evidence is not strong, and they are probably the most debatable. So let me start with those. If you look at the structure on the right, and as their name imply, they are the same medication or in the same class. The difference is the hydroxy group. That's why one called hydroxychloroquine. Those medications are not new. They were introduced and have been used for a long time by rheumatologists. So we have experience, around, you're talking about 70 or 60 years. So we have some good data with regard to safety. But what we don't know enough is their efficacy in COVID-19 infection. Both of those are metabolized by the cytochrome B450, which metabolize many medication, and metabolize into the same active metabolite. So the drugs, the parent drug, have antiviral activity, and the metabolite have also antiviral activity. Is this activity enough? We need more clinical evidence. Comparing the two together, hydroxychloroquine might be more active or more potent than chloroquine, but we don't have a clinical study confirming this. If you look also at the half-life, they have a very long half-life. So we're talking about a month or two as a half-life. So this is maybe one reason why maybe it's not necessarily necessary to give them, as a long duration. Maybe a few days is enough. So I would prefer actually using the shorter duration, partially because of this long half-life. This is their mechanism of action. It's unknown, but this is some suggested mechanism. direct antiviral activity by alkalinization of the viral cell, and this is resulting in inhibiting the viral replication. It could also impair the viral receptor glycosylation. It also has immunomodulatory activity, so it can reduce the cytokine production, IL-1 and IL-6. Also, it can inhibit toll-like receptor signaling. I took this picture from the Saudi FDA website. These are the approved medication by the Saudi FDA. As you can see, we have several products in Saudi approved. You might notice that first, the strengths might be different, but be careful because some of the product are talking about the salt and others are talking about the base. So be careful. They are not the same. Make sure, when you read anything, is it about the base or the salt? Another thing is that we have a syrup for chloroquine, but we don't have a syrup for hydroxychloroquine. So we're going to talk about what to do in that case. I'm going to talk about dose conversion between the salt and the base. Most importantly for chloroquine, because this one, there are different products with different strengths. And also, if you look at different references, sometimes they talk about the salt, sometimes the base, sometimes they mix it together. I have seen even some protocols that made mistakes because of this. So 500 chloroquine phosphate, the salt, is equivalent to 300 base. The tablet we have is 250, so this is equivalent to 150 base. For hydroxychloroquine, less important maybe, but 200 of the salt is equivalent to 155 of the base. Because this is very important conversion. In terms of the dosing, we don't know the right dosing in these cases, even the right duration. We are using similar doses used in other diseases, but we don't know the right dose. There are a lot of those have been tried in the studies. I have selected some of those. Probably one of the most commonly used one is the 400 Q12 in the first day, like a loading dose, and then 200 Q12 for 5 days. This is my preferred dose. Many pharmacists prefer this dose. The nice thing about this dose, not only it was recommended by US CDC, but also there are some in vitro data looking at the pharmacokinetic, and their analysis suggests that this dose might be the best in case of COVID-19. So it's not just some random dose tried. No, there are some data behind it. You will find other doses like the emergency use authorization in the US FDA website. They say 800 per day for 1 day, and then 400 per day for 4 to 7 days. Generally, when it says per day, better to divide it every 12 hours to reduce the GI side effect. Now, Gottfried Philipp, which is very famous because of the studies initially published, although it had a lot of problems. In their studies in France, they use a higher dose, 200 milligram every 8 hours, and for longer duration for 10 days. In case of renal impairment, no need for dose adjustment with this medication. What about chloroquine? Also different dosing. The first one by a multi-center collaboration, and this dose was used in several Chinese studies, 500 Q12 hour for 10 days. Then in the emergency use authorization by US FDA, they recommend 1 gram as a loading dose on day 1, and then 500 for 4 to 7 days. And then one of the most famous doses, and this is my preferred dose, I know a lot of pharmacists prefer this dose as well. It was recommended by several societies, and like the Deutsche Center of Disease Control, it's 1 gram as once. Then after 12 hours, we start 500 and continue on that until the end of the day 5. So it seems for most medication, it might make sense for now to use a loading dose until we have more data. For the National Health Commission and State Administration of Traditional Chinese Medicine, they differentiate based on the weight. So more than 50, we give 500 Q12 for 7 days. If it's less than 50, then on day 3 we start switching to once a day until the 7th day. So yeah, some different dosing, but it seems most recommend 500 Q12 per day with or without loading dose. In creatinine clearance less than 10 with chloroquine, we might need to give half of the dose. This is done also in malaria, not specifically for COVID, but it's usually done, reducing the dose by 50%. Side effect, we have some short-term side effect and some long-term side effect. We use this medication in COVID as short-term, so GI side effects are important. That's why it's recommended to take them with food. They can cause also very important QTc prolongation. So we need to be careful with QTc prolongation. We need to monitor the ECG and try to limit the use of other QTc prolonging medication. It can cause hypoglycemia, extrapyramidal reaction, and in patients with G6PD, it might cause hemolytic anemia. But this is less important with hydroxychloroquine. It's not a contraindication. You can start hydroxychloroquine while you have the results of the G6PD. It's not a contraindication. Long-term use, they can cause retinal damage, especially with chloroquine. This is not maybe a big issue in case of COVID because we use it for a few days. Drug interaction, because they need cytochrome B, some cytochrome B to get metabolized to the active metabolite. If we give strong inhibitors of this cytochrome B, we might reduce the active metabolite. What is the clinical impact? No one knows. We have non-clinical studies at all like these. We have some PK studies, but they measure the parent drug, not the active metabolite. So we don't know what to do with it. So we can't say this is a contraindication, just monitor the patient. Additive drug interaction, other medication causing QTc or hypoglycemia, be careful. In terms of absorption, avoid giving it together with the antacid, separate by 4 hours. There are other drug interaction. For example, we don't know the exact mechanism, like cyclosporin, the serum creatinine increase in one case report. Metoprolol in one PK studies, the area under the curve or systemic exposure was increased by 65%. Most likely the mechanism is through hydroxychloroquine induced cytochrome B 2D6 inhibition. In terms of crushing, because we don't have a syrup for hydroxychloroquine, if you look at the package insert, it might say no, but we can prepare a suspension. And there are some recipes on how to do that. This is one example by the American Society of Health System Pharmacists. Now, going over the studies. Okay, a lot of studies, but I will try to make it short to be updated. So this is the first study that came out using chloroquine. This is just a letter, still not fully published until today. It only said they used, they included more than 100 patients, and chloroquine was superior in terms of inhibiting exacerbation of pneumonia, improving lung imaging, promoting virus negative conversion, shortening the disease course. We don't have any details, not about patient characteristic, not about the dose, not duration, nothing. So we are still waiting for the results of this study. The second study for chloroquine, this is was available just very recently within the last few days, only as a preprint. This is a double-blind RCT. Okay, that's good. They compared high-dose chloroquine, very high dose, 600 milligram of the base, which is equivalent to 1 gram of the salt, Q12 hour, 14 days. And they compared versus low dose, 450 chloroquine of the base, equivalent to 750 salt, Q12 hour on the first day, then Q24 for 5 days. All patients in this study received ceftriaxone and azithromycin, which caused also a QTc prolongation. Guess what? They had to stop this study early. Why? Because around a quarter of patients, 25% in the high dose group experience a QTc more than 500. So this is very bad versus just 10% in the low dose group. So they had to stop the study early. they couldn't assess the clinical efficacy well. There was no difference, but we have small sample size and low statistical power to find a difference. Again, try not to combine with azithromycin. You know, this interaction might be important. Also, maybe avoid very high doses. Stick with the studied doses until we have more evidence. Another study also in that preprint website. This is by Shin Z, RCT. They included moderate COVID-19 patient, so they were not like hypoxic. They compared hydroxychloroquine 200 Q12 for 5 days versus control. Only 31 in each arm. All received standard treatment. They received oxygen, antiviral, antibacterial, immunoglobulin, plus minus corticosteroids. Outcomes: no one died. Progression to severe disease, not statistically significant, but the time until fever resolution and cough relief was shorter in the hydroxychloroquine group. Radiographic change from baseline after course completion, more patient improved in the hydroxychloroquine group. Some good outcomes, but there are a lot of problems with this study. If you looked at the clinical trial registries, they have totally different information, different groups, different treatment, you know, different details. So they are not, they didn't, you know, share the same data as they planned in the clinical trial registry, which is very interesting. So we really need peer review for this study. Why they deviated from what they provided in the clinical trial registry? We shouldn't take this study as a strong evidence for benefit of hydroxychloroquine. For Shenzhen, this is an RCT published, compare hydroxychloroquine 400 per day for 5 days versus control. Just 15 patients per arm. Both groups received conventional treatment, which included inhaled interferon alpha, lopinavir, ritonavir, and omeprazole, also called Arbidol. No difference in any outcome, but very small sample size. Okay, if you look at this study as well, also in the MedRxiv preprint website, this was an unrandomized study, observational. They compared 600 milligram per day versus control, and they included documented COVID-19 pneumonia. Patient also required oxygen more than 2 liters per minute, so hypoxic patient. No difference in this case, interestingly, although they had, you know, relatively good number, around 100 or 90 in each group. No difference in transfer to ICU or death or development of RDS. Okay, and this study, this is also in the same website, open label RCT. They studied a very high dose of hydroxychloroquine, 1.2 gram as a loading dose for 3 days. Nobody have used this dose except them, I think. Then they switched to 800 milligram per day for 2 weeks, if mild to moderate severity, and for 3 weeks in case of severe COVID. So very high doses compared to standard of care. Let's see, with these very high doses, do we get a benefit? If you look at the 28-day negative conversion rate, the primary outcome, no difference. Negative conversion rate at other time point, no difference. The only difference was in the 28 symptoms alleviation rate. So we are talking about symptom relief when they excluded patients who received antiviral agent. Those are the only patients. When they excluded them, they had a significant outcome. But if you look at the confidence interval, it's very wide. So, you know, the precision is not good. Also, the CRP reduction as an inflammatory marker was more with the hydroxychloroquine group. So some symptoms may be relief, but it didn't stop the disease from getting worse, for example. Just some symptom relief with a lot of limitations. So it's not clear. Now we're gonna cover the azithromycin studies. This is the first study, of course, Gottfried Philipp. It got a lot of attention in the social media. They compared, 200 Q8 with azithro, plus minus azithro, just 20 patients versus control. The viral eradication which is PCR negative from nasopharyngeal swab, not the best. They looked at day 6. There was a significant difference. Although initially they planned to look at day 1, 4, 7, 14, not 6. So they changed later. This is concerning. Also, when they compared hydroxychloroquine versus hydroxychloroquine plus azithro, they say 100% of the combination group got viral eradication, but we are talking about only 6 patients. When one of those 6 patients on day 8, the PCR became positive. Also, if you look at the exclusion criteria, 6 of the patients that were not analyzed in the hydroxychloroquine group, they were not analyzed. If you look at them, most of them should be considered as clinical failures. If you look at them, 3 transferred to ICU, 1 died, and 1 had side effect. Also, the viral load was lower in the combination group, and there is an association between viral load and outcome. So we can't really get out, anything, I think, from this study. This is a statement on the journal that published this study. They got a lot of criticism, which made the International Society of Antimicrobial Chemotherapy president, he has to comment on this study. And he said that this study didn't meet the journal standard. They didn't withdraw the study yet, but he made this interesting comment. Another study by Molina also didn't find, it's just a descriptive study, not much from it. Million et al., no control as well. But what's good about this study, also by, this is more than 1,000 patients, but no control group. This is a problem. Good clinical outcome and virological cure in 92%. Mortality was low in this study, and they found an association between poor clinical outcome and low hydroxychloroquine level. So not clear what to make out of this one, although it has big number, but a lot of limitation, including no control group. Some people say, can I use hydroxychloroquine for prophylaxis? We don't have clinical data yet, but I found some data in the COVID-19 Global Rheumatology Alliance Global Registry. They are collecting cases who had COVID-19 infection and have rheumatological disease. So they have so far more than 200 patients. And guess what? Look at the hydroxychloroquine. So 30% of those patients were on hydroxychloroquine, and still they have, they were infected with COVID-19. So this maybe make us not very enthusiastic about the prophylaxis part. Probably no prophylaxis. It's not the best data, but still, if you have hydroxychloroquine, you can still get COVID-19. The last drug I want to talk about is the ritonavir. Ritonavir just inhibits the metabolism of lopinavir to increase its concentration, but the main drug is lopinavir. This one inhibits chymotrypsin like protease of COVID-19. The dose is the same as HIV, no need for renal adjustment. Be careful when you start this medication for COVID-19, you have to rule out HIV because HIV cannot be treated with one medication. So make sure the patient doesn't have HIV. In terms of crushing, it's not recommended generally because one study found that the absorption is reduced by 50%. So what to do if you have only the tablet? You might need to increase the dose. We don't have good evidence, but be careful. The best is if you can bring the suspension. Side effect, most of them come from HIV medication, long-term side effects. So it's not clear which one applies to COVID-19 with short-term use, but they can cause some metabolic side effects, some cardiac side effect, including QTc prolongation, GI side effect, hepatotoxicity, CNS side effect, and some anemia and leukopenia. Drug interaction, very, very important. These are inhibitors of cytochrome B3A4, so it can increase the serum concentration of some medication. Also, interaction with the QTc prolonging medication. With food, the suspension only, not the tablet, just the suspension. its concentration is increased by food. So it's recommended actually to take this medication with food to increase the absorption. The only study I'm going to discuss is this an RCT, okay, open label RCT, compared lopinavir standard dose plus standard of care versus just standard of care for 14 days. They had around 100 patients in each arm. You know, most patients, they have severe COVID-19. But one of the big problem and criticism about this study is that the time from illness onset to randomization, 13 days. So a big delay until, you know, starting the medication. So maybe this reduced the efficacy of this medication. We hope, you know, if they could have started earlier. The primary outcome was in the intention to treat analysis, time to clinical improvement. It was 16 days. Wasn't statistically significant. So unfortunately, the primary outcome was negative. If you look at the secondary outcome, they analyzed the time to clinical improvement using modified intention to treat analysis. And in this case, you know, the result was slightly significant. It was modest. We're talking about, you know, a difference of median 1 day. But it was significant. Mortality, it wasn't significant, but numerically, less patient in the lopinavir-ritonavir died, but this could be due to chance. You know, it wasn't statistically significant, so we can't make that claim. ICU stay was also shorter in the lopinavir, you know, lopinavir-ritonavir. Time to discharge, no difference. This is the main, you know, beneficial finding in one of the secondary outcome. In terms of clinical improvement at day 14, it was 45% in lopinavir-ritonavir and only 30% in the control group. So this is the main secondary outcome that showed it might be beneficial, but it's not very clear, given that many other outcomes are, you know, negative or not significant. On the other hand, GI side effect was more common with lopinavir-ritonavir. 4 patients had to DC because of this reason. Overall discontinuation due to side effect, it was relatively high in the lopinavir-ritonavir. We're talking about 14% of patients have to discontinue due to side effect. So overall, no significant difference, except few secondary outcome. So maybe it's early to totally forget or lose hope about lopinavir-ritonavir. At the same time, we can't conclude from the study that it was superior, and it can cause side effect. Also, if you look at the figure on the right, the viral load, there was no difference between the two groups. And I will stop here and let my colleague, Dr. Dua, continue, inshallah. Thank you.
Thank you, Dr. Khalid, for this excellent presentations. So until Dr. Dua Al-Jafri prepared her slides or get it displayed, I would like to introduce her. Dr. Dua Al-Jafri received her Doctor of Pharmacy degree from King Abdulaziz University. She then pursued a master's degree in Regulatory Affairs and Health Policy from Massachusetts College of Pharmacy and Health Sciences University. Then she completed a pharmacy residency training at BID Medical Center, and then completed a combined training, specialized residency and fellowship training in infectious diseases pharmacotherapy and antimicrobial stewardship at Northwestern Memorial Hospital in Chicago, Illinois, United States. Then she joined the King Abdulaziz Medical City in Jeddah National Guard Health Affairs to work as an ID clinical pharmacist and infectious diseases and antimicrobial stewardship clinical pharmacist. So Dr. Dua, please take it away.
Thank you, Dr. Mohammed, for the introduction, and thank you, لهذا التخصصات, for the invitation. So, Dr. Khalid, you've done a great job explaining the majority or like the most important medications that are being used for COVID-19 management. But I'm going to introduce another drug that has been like very popular in the media as well, which is Tocilizumab. So Tocilizumab is a humanized monoclonal antibody against interleukin-6 receptor, and it was approved for rheumatoid arthritis and cytokine release syndrome. So the dose that has been proposed for COVID-19 management is the same dose that has been used for rheumatoid arthritis or the cytokine release syndrome, which is 4 to 8 milligram per kilogram or 400 milligram standard dose IV, with an option to repeat a dose in 12 hours, with an exception of not to exceed the total dose of 800 milligram. Now, because we're saying it's a weight-based dosing, a lot of institutions have been proposing a weight-based dose rounding. So instead of individualizing doses, they say just use 400 milligram for patients who weigh 50 to 60 kilogram, or 600 milligram for patients who weigh 60 to 85 kilogram, and 800 milligram for those who weigh more than 85 kilogram. Now, this drug has many drug-drug interaction as other drugs like you can imagine. So with immunosuppressants, including the other DMARDs and tacrolimus, there is noted to be some drug-drug interaction, but studies has included patients who are immunosuppressants, who are on tacrolimus and on Tocilizumab, and there was no side effects or safety profile to be noted. In addition, to the drug-drug interaction with cytochrome P3A4 substrates. Now, when I first heard about Tocilizumab for COVID-19, I was honestly shocked. What does Tocilizumab has to do with COVID-19 management? And it's a viral infection, so what's the point? But then the idea that I found behind using Tocilizumab for severely ill COVID-19 patients is just because most of the time severely ill patients had an immune-mediated organ damage, or what we call it cytokine release syndrome, where in which a lot of interleukins or cytokines are elevated, and so here this is where Tocilizumab is actually being introduced and maybe has some role. And so the theory is, just as a result of the similarities between CRS and severe COVID-19 disease, a lot of researchers or scientific researchers have hypothesized that interleukin-6 antagonists may be efficacious for the management of COVID-19 patients. But the question comes into how do we define CRS in those patients? So is there any data that supports Tocilizumab for COVID-19 patients? Well, there are a few studies, but like Dr. Khalid said in the beginning of the lecture, we're going to say a lot of we're going to describe a lot of observational studies. There is no controlled trials yet. So this is a retrospective observational trial of 21 patients. Most of these patients were ICU admitted. They had septic shock, combined organ failure, or severe oxygenation impairment. The dose that has been used, like I said, is the 400 milligram IV. Only 3 patients out of the 21 had a second dose beside the standard of care. Now, they defined standard of care in the study as lopinavir, methylpred, and other symptom relievers and oxygen therapy. The result of this study showed that all of the patients, all the 21 patients, fever curve subsided, so the temperature turned back to normal for all of them. 75 patients had O2 sat, their O2 sat was completely improved. 90% of these patients, their CT scans 1 week after the Tocilizumab administration showed that the lesions were completely absorbed. And the mean length of stay for those patients was around 14 days, 3 days after the Tocilizumab first dose. So I think it's I think the study projects some maybe benefits of Tocilizumab. still, like I said, the lack of comparator group limits the interpretation of tocilizumab specific effect for these patients and warrants caution until more rigorous data are available. Another study, another observational study, and of course, both studies were conducted in China. This observational study included 15 patients. Now, what is unique about this study is that all of their patients had an interleukin-6 level assist, and all of them had an elevated interleukin-6 level prior to initiation of tocilizumab. 6 out of the 15 patients were severely ill, whereas 7 out of them were like critically ill patients. Some of these patients had not only tocilizumab, but also methylpred in combination with tocilizumab. The goal of this study was mainly to assess the CRP and the interleukin-6 levels pre and post the tocilizumab infusion. And so what they found is like there is a significant reduction after the tocilizumab therapy in both CRP and interleukin-6 level as expected. But I think what makes this study unique is that they only included patients who had interleukin-6 level elevated, which probably the question that have been arised by a lot of institutions, if we don't measure interleukin-6 level, are we supposed to be given tocilizumab for our patients, or should we just basically hold off tocilizumab or not maybe consider tocilizumab? So I guess this comes back to if tocilizumab is very effective and it has shown benefits, why don't I use it to all of my patients? I mean, despite it's like very expensive drug, but beside the cost issue, what are some of the downside anyways of tocilizumab? So some of the side effects that has been published and have been seen in the literature is tocilizumab, just like any other monoclonal antibody, it increased the risk of fatal infections. Basically TB, invasive fungal infections, and other viral infection. And so in a country like ours where TB is a pandemic and a lot of patients, like we all maybe at some point had latent TB, probably considering checking the TB quantiferin is crucial, and maybe the risk outweighed benefit here, and we should probably keep this in mind before administering tocilizumab. Another side effect that has been seen is the risk of neutropenia and thrombocytopenia, beside increased LFTs and hepatic injury, also like documented. In a meta-analysis that has been, that basically involved all the rheumatoid arthritis studies, it was shown that tocilizumab has significant high risk of infection, and in particular, the higher dose of tocilizumab. So maybe this can suggest that higher doses of tocilizumab can maybe increase the risk of infection. But the conclusion of that meta-analysis showed that maybe we should probably be very mindful of translating this result, because not all the patients with who were on 4 milligram per kg had increase of infection like tuberculosis or like hepatitis, or increased incidence of malignancy. So the bottom line of all of this: should we use tocilizumab? Should we not use tocilizumab? I guess there is still no clear evidence. All of these evidence were observational trial. The risk versus benefit assessment is crucial here. The most important thing here is, and I guess like the question that has been raised by a lot of people is like the cytokine monitoring. So cytokine levels and interleukin level is like not being monitored in all institutions. And this is mainly because the cytokine level is not very, the cytokine measurement is not very specific. You can measure the cytokine level in peripheral blood, but it may not correlate with the immune response in deep tissue. Beside the fact that the interleukin 6 level in particular require like a specific sampling parameter and like timing in the day. So some people have suggested using indirect parameters like CRP or ferritin and D-dimer that can be used as an indicator for CRS, and therefore, like if they were elevated, you can use Tocilizumab for these patients. Moving on to another drug that has been proposed also in the media, but not probably, but haven't reached here in Saudi Arabia yet, which is Favipiravir. So Favipiravir is a RNA polymerase inhibitor. It isn't FDA approved nor Saudi FDA approved, but it's licensed in Japan and China for the treatment of influenza, and I guess they tried to use it for COVID, and I'm gonna talk about this later in some of the studies. But this is where Favipiravir is coming from. So it's coming from Japan and China. With dosing, I guess various dosing regimens have been proposed based on the type of indication, and I couldn't find a specific dose, but in the two studies that are now conducting, the doses are being used for COVID-19 is a loading dose and then a maintenance dose. So a loading dose of 2400 to 3000 milligram Q12 on day one, and then maintenance dose of 1200 to 1800 milligram every 12 hours for 7 to 10 day duration. Generally, the drug is very well tolerated. I haven't seen any side effects reported out of secondary to Favipiravir. Now, when I talk about Favipiravir, probably a lot has heard about this study. It's a study that was conducted in China, a small open label, non-randomized clinical trial compared Favipiravir plus interferon alpha versus historical control. So patients who received lopinavir, ritonavir plus inhaled interferon alpha. And so the result of this study was amazing. So they found out that the median time to viral clearance was very short in the Favipiravir group. So 4 days versus 9 days in the lopinavir, ritonavir group. And so after the study, a lot of people has been more leaning toward getting Favipiravir in the country and maybe get some hope to treat their COVID-19 patients. But then guess what? The journal has temporarily removed the trial. And so they said specifically that they're regretting that this article is removed, and that we're supposed to be waiting for a replacement as soon as soon as possible, as soon as the authors remove, correct the reason behind the removal. In another study that compared Favipiravir versus Arbidol, which is another antiviral, I guess we're not going to talk about it here, but it's also been used in China for influenza. So this study compared both regimen for patients with moderate and severe symptoms of COVID-19, and it was found. So they stratified the result based on the severity of the disease, and as you can see here, the clinical recovery rate at day 7 in patients with moderate COVID-19 pneumonia was really high in the Favipiravir group in comparison to the Arbidol group. same as for severe patients, but it didn't reach the statistical significance, but I guess the number here speaks. So more severe patients were in the Favipiravir group, and this may show that the Favipiravir group here, the Favipiravir has maybe some benefits in treating moderate and severe patients with COVID-19. The issue with this study is basically that it has probably a lower number, and there was no randomization, so it's observational study. Although they compared, like there was a comparison between two groups, so maybe this can add some good thing to the literature. Are we gonna have Favipiravir here in Saudi? I don't know yet. I guess we're waiting for more insights from the Ministry of Health. Moving on to another antiviral drug, which is remdesivir. So remdesivir has been in the news, maybe more than Favipiravir, despite that it's like not approved anywhere, which is kind of interesting to me. So remdesivir is still an investigational drug everywhere. It was developed in response to the Ebola outbreak from 2013 to like 2016. Basically the dose that is being recommended for COVID-19 is exactly the same dose that has been used for the Ebola outbreak. There is no hepatic or kidney adjustment with remdesivir, but the manufacturer has listed creatinine clearance less than 30 ml per minute as a precaution or like a contraindication for remdesivir use. In terms of its safety profile, one has to monitor the hepatotoxicity and the nephrotoxicity, as the IV formulation of the drug it contains cyclodextrin. So is there any data that support remdesivir? Yes, the story first started with some case series and multiple case report, but the first case series that appeared was using remdesivir in 5 patients. 3 of them were critically ill patients who received remdesivir in ICU settings. The first patient basically received remdesivir, but discontinued because of like the hepatic enzyme just increased, and so therefore they had to discontinue remdesivir in this patient. So I guess this maybe highlights some maybe insight about the safety profile of remdesivir, and so it should be taken under consideration if we ever get remdesivir here in Saudi Arabia. The second patient was treated with remdesivir and discharged. The third patient, though, he received a couple days of remdesivir, and then he also developed other issues. So they started the patient on voriconazole, IV voriconazole, which basically had also cyclodextrin. So, and the patient developed AKI, and the patient was started on CRRT. And so they say in the case series that maybe the CRRT was secondary to the like nephrotoxicity that resulted from both combination. I'm not sure, honestly, and they don't even give more insights about or more specifics in terms of why like maybe this patient has some baseline characteristic that contributed to AKI. The other study that has gotten the most of the attention is the one that was published in the New England Journal of Medicine. And this is basically an observational, again, one-arm, multi-center study of 61 patients who received at least 1 dose of remdesivir. Of these patients, somewhere in the US, somewhere in Europe, and others were like in Japan. At baseline, 30 patients, which is around like 60% of the patients received were receiving mechanical ventilation, whereas 4 patients were on ECMO. The result of this study just show some insights, some like maybe benefits of remdesivir. So you can see that as you can see here, like some patients had improvement in oxygen support, and 60% of these patients who were receiving mechanical ventilation were extubated. And the mortality rate of this study was 18% among patients who were receiving invasive ventilation, and 5% among those who were not receiving invasive ventilation. So bottom line, this may show some benefits of remdesivir, but again, this is only one arm, observational. A lot of question has been raised about whether we should get it here in Saudi Arabia or not. So with that, I'd like to maybe shed some light on one of the trials that has been that has been now conducted worldwide. It's the Solidarity clinical trial for COVID-19. And basically Saudi Arabia, it looks like it's like one of the participating sites. So if you want to know more whether we can use remdesivir, whether you can use remdesivir, or whether you can be a participating site in this study, I guess you can conduct, you can maybe contact, sorry, with the Saudi FDA or maybe the Ministry of Health, and ask more about the eligibility of your patient to be enrolled in the study. So moving on to not a drug, but something that also has been raised and had a lot of attention, which is immunoglobulin. And so basically the rationale of immunoglobulin or convalescent plasma or hyperimmune globulins is that antibodies basically from recovered patient may help with both the freeing the virus and infected cell immune clearance. And in one of the articles, like the JAMA article that was conducted among 5 critically ill patients who received convalescent plasma, they specify what's the donor criteria. So all of the donors were COVID-19 confirmed. They had a subsequent COVID-19 negative PCR. They looked at the other like respiratory viruses and like syphilis, HBV. So they confirmed that they're negative of all of these other like viral infection. One important criteria is that the patient were asymptomatic for more than 10 days. So something to keep in mind. And so the procedure basically was getting 400 ml of the convalescent plasma from each donor by apheresis. And then the plasma immediately was transfused to those recipients on the same day it was obtained. The result of this study basically showed that all patients who received, sorry, I'm saying this study, it's a case series. So all of the 5 patients in this case series, the temperature, they clinically improved. Their temperature was, the fever was subsided, and their viral load was completely negative 2 or 3 days post the transfusion. Same has been, the same result has been shown in another trial or in another case series of 10 patients. So I'm not going to repeat that for the sake of time. Okay. So I guess before I move into before I move into the third objective of this our webinar, I just wanted to highlight some special populations. So patients who are pregnant. What do we do with pregnant ladies with confirmed COVID-19? So pregnant ladies with confirmed COVID-19, looks like the China COVID-19 guideline has listed lopinavir, ritonavir as the first line treatment the first line for treating those patients, which makes sense. Lopinavir, ritonavir is basically so is a protease inhibitor, and protease inhibitors are safe in treating HIV pregnant ladies. So the safety profile probably is fine. But then they put some question about hydroxychloroquine, which probably in this case, we are going to need to extrapolate other data from patients with autoimmune disease who are on hydroxychloroquine for a long time. So I've been looking into some data and the safety of hydroxychloroquine. And it looks like there is a systematic review of which they included 5 studies. 4 of them were observational. 1 of them was randomized clinical trial. And the goal of the study was just to assess whether the incidence of congenital defects or live birth or like fetal death is more common with hydroxychloroquine or versus control or like placebo or not. And as you can see here from the pool, the forest plot, you can tell that it's favoring at hydroxychloroquine. So basically the odds ratios of congenital defects or even the live birth is lower with hydroxychloroquine than placebo, which makes it kind of reassuring to use hydroxychloroquine for patients, for pregnant ladies with confirmed COVID-19. Despite the fact that now we don't know if hydroxychloroquine is actually even effective for patients with confirmed COVID-19 or not. The last drug that has also been proposed is remdesivir, and the manufacturer now is compiling some data and conducting controlled trials in Europe on pregnant COVID-confirmed patients. So I guess we're going to wait for the result of the safety, but they're recruiting people with the same dose of like adult dosing. So with pediatrics, all of these medications probably are safe to be used in pediatrics, just in terms of extrapolation, but unfortunately there is no specific trials that was conducted in peds to use any specific drugs, or the recommendation to use any specific drug over another, which is probably very similar to adults, to like treating adults with COVID-19 at the same time. So moving on to our last objective of this trial, or of this webinar, sorry, which is mitigating drug shortages during this pandemic, which is honestly has been a nightmare. The issue with drug shortage is a lot of significant increase in the demand of certain medication now. What we're facing. So a lot of COVID-19 medications now has been needed, and unfortunately, a lot of manufacturing and supply issues have been raised. So getting medications worldwide is actually now difficult with all what we're going through right now. So I thought maybe we can probably talk about the process for management of medication shortage in general that has been proposed by the ASHP. So the ASHP has put a very nice guidance on how to manage these drug shortages in like these times. And so the main steps is basically first planning for a drug product shortage before it occurs, and then responding to the product shortages as they happen along. I'm not going to go in details because I want to talk about our experience here, and I know we're short of time. The European Commission has also put in a nice stepwise approach, or things that they have been conducting, and also I'm not going to talk about them in detail, but all of these steps has actually been done, and I've seen it. I've seen some things from the Ministry of Health, and I've seen some things here at some things that we have done or experienced at the National Guard. So providing equitable distribution of available medications among all institutions in the kingdom, or like in Europe. This is basically something that the Ministry of Health is actually working on. So one of the initiative was just to hold off hydroxychloroquine and chloroquine and Kaletra, and basically stockpile all these medications in the Ministry of Health. And so now these medications are not allowed to be prescribed. Like if you go into a community pharmacy, you're not allowed to get on any of these medication. And if you go to, if you're in the institution, supposedly you're not supposed to be taking any of these medication as well, unless you have confirmed COVID-19 or you've been on it for a long time before for other indications. Another thing that I want to highlight is providing an alternative medication list. Like looking into the current stock and maybe providing alternative list to the medication that you're going to run into, you're going to run short quickly, or you anticipate running short in. Exchanging hospital protocols to treat patients. This is actually also one of the things that probably all of you here are aware of. So the Ministry of Health has provided a protocol for patients suspected or who has confirmed COVID-19, which has been very helpful. And I know a lot of institutions has been using or has been following the Ministry of Health protocol as a guidance in what to use and which drug to use and when. So our experience at National Guard West Region is basically, we, like everyone else, we planned this ahead of time. So we coordinated, we made a team, we made a drug shortage team. This drug shortage team has to coordinate with logistics for medication supply and set a plan for drug shortage. We implemented an electronic healthcare restriction for medications expected of increased use for management of COVID-19 patients. And this was approved by our P&T committee. The hospital admin people has formed a COVID-19 scientific committee to prepare and keep updating the guidelines to manage patients with COVID-19 as well. And so therefore, so the off-label use of any COVID-19 patient now is according to our hospital guideline to avoid any confusion or avoid any fear. The storage of this medication now is actually under the controlled substance in our institution. And so we have asked our pharmacists to exercise extreme vigilance in verifying orders for medications used for management of COVID-19 for appropriateness of dose, duration, indication as per the hospital guideline. So before we end up our webinar, I just wanted to talk about some take-home points. We kept saying during this webinar throughout the presentation, and I'd like to say this again, that there is no approved medication for COVID-19 yet, and all current literature do not support using one medication over another. Therefore, careful consideration should be applied, and each patient should be treated individually. So, what all institutions, protocol, and international guidelines have been agreed on is that due to unclear evidence on managing COVID-19, we're not supposed to be starting any patient empirically without clear confirmation of COVID-19 on any of these medications that we talked about during the presentation. Lastly, like I said, we're running into a disaster of drug shortage worldwide, but I think with collaboration and preparation, we can still do something, and we can still cooperate and avoid further issues with in terms of drug shortage. With that, I conclude my presentation, and I think we're ready to take maybe questions.
Okay, thank you so much, Dr. Khalid Al-Ja'li and Dr. Dua Al-Jafri for this enlightening presentations. We are so glad to see the number of participants has reached to the maximum capacity that can be taken by this program, which is 10,000 participants. And also we would like to apologize for those who registered for this webinar and could not join us because of the maximum capacity that can be taken by the program. So we had almost 14,000 people who registered for the webinar. I would like also to mention that this webinar has been recorded and will be uploaded to the Saudi Commission for Health Specialties website within the next week, inshallah. So we received a lot of questions, over 900 questions, and due to the limitation of time, we will take a few questions for the next 10 minutes. And I will ask some of these questions that got repeated so many times. So Dr. Khalid, although you have mentioned it during your presentation, but can we use hydroxychloroquine as a prophylactic or as a prophylaxis, especially for those who work in the healthcare or the healthcare practitioners? Dr. Khalid, can you open your microphone?
Okay, Dr. Muhammad, can you hear me?
Yes.
Okay, I tried to have the video, but I think it's not working.
Yeah, we can see you, Dr. Khalid. Go ahead.
Oh, you can see me? Okay, I can see myself. Okay. Okay. Okay, very good question, actually. So, you know, because hydroxychloroquine, because of its mechanism of action, it can alkalinize, you know, the viral cell, so might reduce replication of the virus. So it's thought, since we are using it for treatment, so why not for prophylaxis? The issue is that we don't have any clinical evidence proving that it can, you know, really prevent COVID-19 infection. Not only that, but as the data I shared, you know, I looked into the, you know, one of the rheumatology registry in US, and so far they collected around more than 200 patients, and around 70 patients have been on hydroxychloroquine. Can you believe this? 70 patients have been on hydroxychloroquine and still they had COVID-19 infection. So it's not the best data. We don't have details about the characteristic of the patient or anything, but it tells you that, you know, maybe maybe it's not very protective, you know, because, you know, 70 out of 200, you know, still had COVID infection. So I wouldn't use it honestly for prevention, and honestly even for treatment. It didn't prove it's a very good medication. It's still unclear. So I wouldn't use it for prophylaxis, especially for prophylaxis. You're going to use it for longer duration, and you don't know, you might get more of the, you know, long-term side effect or QTC prolongation or anything. So I don't think it's you know, maybe the safest medication, and there is doubt in its efficacy, even as prophylaxis.
Okay, great. So we had a lot of questions regarding the role of vitamins in treating patients with COVID-19, especially vitamin C and D. Can you comment on this?
Yeah, so, okay, vitamin C has been tried in everything. You know, any infection, even non-infectious diseases have been tried, you know, but do we have any clinical evidence that it can help? No, zero evidence that vitamin C can help. As you know, even in some viral infection, maybe influenza, common cold, and others, you know, most studies didn't find, you know, a benefit. Is it harmful? Maybe it's not very harmful. It's a water-soluble vitamin, so not one of the, you know, toxic products, but I doubt that's going to help. If it's going to help, I think only use it when we have some data, but so far we don't have clinical data.
Dr. Dua, we had questions about what would be the cutoff for QTC to start hydroxychloroquine?
So I guess there is no clear cutoff to start not to start hydroxychloroquine, but one thing to keep in mind, there is a protocol that was actually posted in by Mayo Clinic, and I actually love it, and I'm gonna refer to it. They basically are saying that patients who had QTC more than 500 honestly more than 480 should be we should probably just be mindful of not using hydroxychloroquine in these patients, or not to start hydroxychloroquine if they are on other treatment or other agents that can prolong QTC. So I'd say 480 can be a cutoff, especially for patients who are on other agents, other QTC prolonging agent. Anyone who has QTC that is less than 480, probably using hydroxychloroquine on those patients is fine, with close monitoring and on a daily basis.
Okay, thank you. Also, we had a question: is acyclovir helpful in treating patients with COVID-19?
So not that I am aware of. I have not came across any study that used acyclovir for COVID-19. I'm not sure if you have any other answer, Khalid.
No, I don't think so. This is only for herpes viruses. I don't think it works on any other clinically important viruses.
Okay, so another question with regard to patient proved to have G6PD, what would be an alternative treatment for them that can be used?
Okay, yeah, so, the issue of G6PD, this is with this quinoline group, hydroxychloroquine, chloroquine, but it's not an issue with the other medication. So you can use, if it proved to be effective, we can consider other medication. But the main issue is with the chloroquine, hydroxychloroquine, and mostly with the chloroquine. But hydroxychloroquine, the risk is low, no evidence that we should, avoid it. Many protocols and experts say, start it, don't halt, and just monitor later G6PD. So it's not a contraindication, and it's only an issue with these medication, not the rest.
Okay, so a common question with regard to the use hydroxychloroquine over chloroquine. When do you recommend to use one over the another, or what would be the differences between them?
I'm sorry, can you repeat the question, Dr. Asiri?
So a common question that we receive, the differences between the hydroxychloroquine and chloroquine, and when do you recommend to use one of them over the another?
Well, unfortunately, there is no clear evidence on not to use when to use which in particular. But I'd say as a safety profile of hydroxychloroquine tends to be way safer or better than when compared to chloroquine. There is no specific, I want to say there is no specific situation for me, except for the G6PD deficiency here, where some data that says in patients who are G6PD deficient, probably you want to avoid, definitely, it's like chloroquine is definitely should be avoided, but not hydroxychloroquine.
Okay. So another question, when do you think Tocilizumab could be a potential option for COVID-19 patients?
This is an interesting question. So I'd say Tocilizumab should be a potential option for patients who are severely ill, who are in basically the cytokine release syndrome. So I know it's hard to diagnose or to know if the patient is in a cytokine release syndrome, or when is this patient in the cytokine release syndrome. But basically those patients who are critically ill, who has high or elevated CRP, who has high ferritin levels and high D-dimer levels, those are the patient who I would be more leaning toward giving them Tocilizumab.
Okay. So we had a question about the role of ivermectin in treating a patient with COVID-19.
Yes. So
can you please comment on this?
Yeah. So ivermectin, as we know, it's used, for example, for lice and other uses. There is this study. It's not clinical study, in vitro. Showing that ivermectin could reduce the viral replication by, I believe, 50%. Okay. In the lab, okay, this is interesting. Now we should test it clinically. But do we have any clinical data? Zero.
Yeah, I agree. And correct me if I'm wrong, Dr. Khalid. Ivermectin is not available as actually capsules here in Saudi Arabia, right?
Yeah, I'm not sure. We don't have it in our institution. I'm not sure if others have it. I'm not sure.
Yeah, I mean, it's definitely US FDA approved, but I don't think it's available here in Saudi Arabia.
Okay. So with that, I think due to the limitation of time, we concluded our webinar. I would like to thank Dr. Khalid Al-Jali and Dr. Jeffrey for the excellent presentation that they gave. Again, I would like to mention that this webinar is recorded and will be posted and uploaded to the Saudi Commission for Health Specialty website within the next week. Dr. Wissam Abu Znada, the Executive Director of Training in the Saudi Commission, would like to give a few words at the end of this webinar. Dr. Wissam.
السلام عليكم جميعا. اخواني واخواتي، الله يديكم الصحه والعافيه ان شاء الله. يعني اخوي محمد، اخوي خالد، واختي خلود، الله يديكم الصحه والعافيه. ابدعتوا ويبنار ما شاء الله تسجل فيه فوق ال 14,000 وحضروا كونسيستنتلي الى الان 10,000 واحد. وهذا الماكسيموم حق زوم الحالي. فالله ما اقدر اقول لكم الا الله يكتب اجركم وينفع بعلمكم ويطرح البركه في انجالكم ان شاء الله. وان شاء الله ربنا كده يعني يزيل الجائحه دي ونرجع طبيعيين مره ثانيه. بس ما اعتقد انه الويبنار هذا اصبح جزء من الحياه، واعتقد الفائده منه جدا رائعه، وان شاء الله كده نستفيد منه اكثر واكثر ان شاء الله. مشكورين مره ثانيه، وشكرا لفريق الدعم اللي ما هو باين في الصوره دائما واللي يستحملوني مره كثير. فالله يديكم العافيه جميعا، وشكرا للحضور جميعا على تفاعلكم الرائع اليوم. شكرا شكرا شكرا، الله يديكم العافيه.
يعطيك العافيه دكتور وسام.
يعافيك دكتور.
نراكم ان شاء الله على خير في الويبينارات القادمه باذن الله. في امان الرحمن.
في امان الله. السلام عليكم.